Okay, good afternoon, everyone. May I ask you to have a seat? And please, as a courtesy to the speakers and fellow delegates, ensure that your mobile phones are turned to a silent mode during the session. I all welcome you to this neuroendocrine tumor session, Oncology 2, and I'm happy to chair this session together with Dr. David Patterson. And I would like to ask the first speaker, Dr. David Chun, who comes from Sydney North Shore Hospital and is a medical oncologist, to give us a clinical overview of neuroendocrine tumors.
Thanks very much, Professor Boak. So I know that there's a couple of speakers after me, and the educational objective of this session is to provide a clinical overview of neuroendocrine tumors. In the next two parts of this session, we'll talk about PET imaging and PRT. So for this session, I think the aim would be to understand the heterogeneity in neuroendocrine tumors, to describe the challenges in diagnosing neuroendocrine tumors and the modalities we use generally, and also to discuss classes of treatments in NET and when we would consider each one. So the overview is to start with a background, talking about the epidemiology and etiology of neuroendocrine tumors, and I'm going to spend some time talking about the different management options. So neuroendocrine tumors are generally characterized by the ability to produce hormones that may lead to symptoms, so both functional tumors and non-functional tumors. It is a very heterogeneous group, both in terms of the primary site of disease, so you can have pancreatic, midgut, foregut or hindgut neuroendocrine tumors, as well as heterogeneity in terms of their clinical outcome. Some patients with very benign disease may live for more than 20 years without the need for treatment, whereas other patients with aggressive disease may have an overall survival of less than 1 year, despite optimal treatment. We've come a long way in the last century in terms of progress in neuroendocrine tumors. Obendorfer was a German pathologist who first coined the term carcinoid, meaning a cancer-like syndrome. In the 1950s, there was a description of carcinoid syndrome, as well as carcinoid heart disease. And serotonin at that point, or 5-hydroxytryptophan, was identified as the hormonal basis behind neuroendocrine tumors. Over the last 30 years, there have been the development of different pathological classification schemes for NETs. And over the last 10 years or so, there have been multiple large randomized controlled trials that have provided a solid evidence base for the treatment of neuroendocrine tumors. This is a graph looking at the incidence of neuroendocrine tumors. It's classically been thought of as an uncommon or rare malignancy, but you can see from the graph that whilst the incidence of all cancers has remained relatively steady, this is a population-based analysis from Canada, the incidence of NETs has increased. And we see this in multiple series, including in the SEER database, which we're going to look at in the next slide. So from 1994 to 2009, the incidence nearly doubled. And I think part of this could be due to increased diagnosis as we use more cross-sectional imaging, but part of it could be due to an actual increase as well. Now is the second most prevalent malignancy in the gastrointestinal tract after colon cancer. And the exact percentages differ in terms of their distribution across sites, but in this particular study, there was an update last year by Dasari et al. 2/3 of the patients had a gastrointestinal primary, most commonly in the small bowel, the pancreas and the rectum, 1/4 in the lung, and approximately 15% from other places, such as the ovary or the head and neck. Neuroendocrine tumors of the gastrointestinal tract are graded by two things: the mitotic count, as well as the Ki-67 index. Pathologists use the higher of the mitotic count or the Ki-67 to determine the grade. So for example, if someone had a mitotic count of 3, but a Ki-67 of 35%, they would still be considered as having a grade 3 neuroendocrine tumor. More rarely, patients can have a combination of both adenocarcinoma as well as neuroendocrine carcinoma, with at least 30% of each, leading to the diagnosis of MANEC, which is now called MINEN. You can see from one of the seminal papers that grade affects prognosis and is one of the major determinants for prognosis in all patients. There was an update last year for the pancreatic neuroendocrine tumors. The main change in this was the division in grade 3 neuroendocrine tumors between well-differentiated grade 3 NETs, NET, and poorly differentiated NECs, so neuroendocrine carcinomas. And neuroendocrine carcinomas have a poorer outcome, and they tend to have a Ki67 of above 55%, although there is some overlap between the two. But I just wanted to remind you that this is only for pancreatic neuroendocrine tumors at the moment, rather than for other ones. You can see that histologically and morphologically, poorly differentiated neuroendocrine carcinomas look very different to the well-differentiated ones. So on the right-hand side, you can see that there are small, bizarre-looking nuclei, and on the left-hand side, well-differentiated neuroendocrine tumors still retain some morphology. Again, poorly differentiated neuroendocrine carcinomas have a poorer outcome compared to well-differentiated tumors. In terms of etiology, there's no specific strong risk factors that have been consistently identified for patients to have neuroendocrine tumors. Family history tends to be a risk factor, and diabetes tends to be a risk factor as well. However, smoking and alcohol are not risk factors, and one study actually showed that maybe it was potentially a mildly protective factor. Don't quote me on that, though. Approximately 10% of neuroendocrine tumors are genetic, and those patients usually present with a very strong family history. Many of these diseases are autosomal dominant, meaning that they pass through generations, with many patients being affected at a young age. The most common genetic causes are MEN1, MEN2, as well as less common ones such as von Hippel-Lindau disease and neurofibromatosis. Interestingly, BRCA, which is a familial breast cancer gene, is associated with pancreatic neuroendocrine tumors as well. There's obviously an increased frequency of neuroendocrine tumors lifetime for these patients, and there are obvious implications for screening. No one's so sure about whether this causes a change in management for these patients who have been diagnosed with a NET, though. I talked to many patients diagnosed with neuroendocrine tumors, and delayed diagnosis is unfortunately the norm. This is a graph from a patient-reported survey held in conjunction with INCA. And you can see that the mean number of healthcare providers seen before NET diagnosis was 6. And actually, patients had an average of 11 visits to healthcare providers before a diagnosis of NET was reached. This can go on for many years. Fortunately, with increased awareness and the use of better modalities in imaging, maybe we can decrease that lead time to diagnosis. Histology is very important in confirming diagnosis because, as we'll look at, biomarkers are poorly specific for this disease to date, and the symptoms can be very non-specific. So we talked earlier about the fact that there are two types of neuroendocrine tumors, those that are non-functional and those that are functional. Functional NETs are defined as those that produce vasoactive hormones, resulting in significant clinical symptoms. So flushing, diarrhea, and bronchoconstriction, and if this continues, carcinoid heart disease. This is more likely with patients who have hepatic metastases. In patients with pancreatic primaries, they may have symptoms of specific hormone excess, such as an insulinoma or glucagonoma. Because of the increased use of cross-sectional imaging, though, non-functional tumors are becoming more and more common. So the percentage of functional tumors approximately 20 years ago was about 50%, and that's decreased to about 20 to 25% on recent analyses. These may often be asymptomatic and present with years of non-specific abdominal discomfort, pain, and ultimately something like obstruction, which leads to the diagnosis. Diagnosis is usually aided by imaging, so conventional cross-sectional radiology such as CT and MRI, as well as ultrasound. There are less conventional radiological modalities which are very useful in this disease. So for example, CT enterography, where available, can determine the presence of a small bowel primary, or even if a small bowel primary is known, it may show the presence of multiple small bowel primaries and help surgical planning. Biopsy can be aided by medical imaging, and I'm going to let my colleague speak about the role of nuclear imaging, which is obviously very large in this disease. You can see the great difference between the CT abdomen and the 68 gallium dotatate PET in a patient treated by our institution. In the CT abdomen, you can see the obvious hypervascular liver metastases, but there's functional imaging which gives even more information about this patient. We use several biomarkers in practice, but to be honest, none of these are very useful. So plasma chromogranin A is very often employed for monitoring of neuroendocrine tumors. It's increased in approximately 60 to 80% of GEP-NETs, but it's horribly non-specific, so patients who have a presence pump inhibitor on board, they may have an elevation to 2 or 3 times the upper limit of normal, and this obviously causes a lot of stress for the patient, multiple investigations ongoingly. Chromogranin can also be increased in other pathology, as well as renal failure. Right now is the best thing we have. People have looked at things such as chromogranin B or pancreastatin, but these are not in wide clinical practice at the moment. On the other hand, urinary 5-HIAA is highly specific, but it has its own problems. So a long collection time, approximately 24 hours. Because these tests are batched, it may take 2 or 3 weeks for this assay to come back, and there's dietary restrictions as well. Finally, this is a less sensitive test, so it's not necessarily increased in all patients with neuroendocrine tumors. If the patient has an elevated urinary 5-HIAA, because this is a metabolite of serotonin, we would suspect a functional component to their disease. We would test for specific hormones such as insulin or glucagon, only if there was clinical suspicion of a hormone-producing syndrome. So diagnosis should be optimally confirmed with histology and plenty of histology. So a fine needle biopsy is usually not adequate to accurately grade the tumor. And that's because the Ki67 stain only stains a small percentage of cells. So if you only have 500 cells, say, from a fine needle biopsy, it's a very fine demarcation between a grade 1 and a grade 2 tumor. So 1 or 2 positive cells might change your classification there. So ideally, a large surgical resection specimen, an endoscopic biopsy or a core biopsy would be helpful in fully grading the patient. Chromogranin A is the most useful marker, but other markers such as synaptophysin and NSE for high-grade disease, as well as markers for origins the primary origin, such as CDX2 and TTF1, may be helpful as well. I can't emphasize this enough. If you go home with one message, mitotic count Ki67 index, we really need those to optimize treatment for patients. There have been a few studies in the last 5 years that have changed the way we look at neuroendocrine tumors and helped our understanding of the basic science behind them. So there was a paper in Science in 2011 that looked at whole exome sequencing of 10 pancreatic neuroendocrine tumors with additional analysis in about 60 cases. This showed that neuroendocrine tumors have common mutations in MEN1, DAX-ATRX, and the mTOR pathways. And more importantly, that they're genetically different to pancreatic adenocarcinomas. These were all well-differentiated NETs, and there was a follow-up study by Scarpa et al., which was published in Nature last year. I think this is a seminal paper in NET biology, which we'll continue referring to over the next few years. So there was whole exome sequencing of 102 pancreatic neuroendocrine tumors, and this demonstrated that there were 5 distinct mutational signatures, one of which was novel and 4 of which have been known about previously. There's a few things I want to take away from this slide. The first one is that there was a lesser mutational load compared to pancreatic adenocarcinomas. So this may have implications for things such as immunotherapy in neuroendocrine tumors, but I think we need confirmatory studies in this field at the moment. The second thing is the criticality of MEN1 in neuroendocrine tumor pathogenesis. So as we talked about before, MEN1 can be a germline mutation, so it's mutated in all the cells of the patient, and those patients get neuroendocrine tumors very early on in their lives. However, it can also be mutated in sporadic neuroendocrine tumors, and I think that was an important finding of this paper. The other thing that it showed was that MEN1 was at the center of a lot of the different genetic mutations found in neuroendocrine tumors. Changes in some of the signaling components correlated with poorer prognosis, and hopefully this may have implications to optimize therapy later on. So I wanted to talk about the different therapies that are present in neuroendocrine tumors because it's complex and is dependent on both histology, radiology, and functional imaging. The modalities we'll talk about are surgery, even though I'm not a trained surgical oncologist, local therapies, so liver-directed therapies, and systemic therapies as well. This is one of the models for multidisciplinary care. And I think because of the number of modalities available, it's important to involve the surgeons, medical oncologists, nuclear medicine physicians, radiation oncologists, depending on the field, and try and keep the patient in the center of all the management plans. We know that there's a little bit of data as well that multidisciplinary care may improve outcomes in patients. And so this is a paper approximately 10 years ago of Australian patients diagnosed with metastatic neuroendocrine tumours. So it was a study looking at patients who were managed at the medical oncology unit, which was a specialist unit compared to those managed in the community. And patients who were managed in the specialist unit had a longer survival. Obviously, there's a lot of biases that could be present in a retrospective analysis, but one of the interesting things was that most of the patients in the specialist unit received treatment with a somatostatin analogue compared to patients in the community who did not. And whilst most clinicians would agree that SSAs are now the standard of care, I think this demonstrates that in a complex disease, specialist centers may be able to adopt good therapies earlier or have earlier access to these therapies. Surgery for localized neuroendocrine tumor is the standard of care. So if you can cut it out, you should cut it out. And it's the only chance for cure in this population to date. Specialty input is preferable for small bowel resections particularly, because the surgical technique is different to that for a colorectal carcinoma. And CT enterography should be considered preoperatively for small bowel lesions due to the fact that approximately 10% of patients have multifocal primaries. There's no standard follow-up regimen after R0 or R1 resections, and this is just a table showing the different recommendations. So no one can agree as to which modality we use, whether it's cross-sectional imaging, cross-sectional and nuclear imaging. No one can agree how often, and no one can agree how long we should do it for. We looked at some data in Canada recently in 738 patients, and this was looking at recurrence rates for all patients across the province. So the main thing I wanted to draw from this graph is there's a really long time to recurrence. So if you stop, so I'm just going to try to use the pointer. If you stop monitoring at 5 years, you can see that approximately half of the patients recur after that time for both pancreatic as well as small intestinal neuroendocrine tumors. So this would argue for a long period of observation for, say, at least 10 years and perhaps even longer than that, particularly for small bowel neuroendocrine tumors. If we're monitoring for that long and patients have indolent biology, then maybe we should do imaging less often, because we obviously shouldn't image people for 10 years at 3-monthly intervals. So we're trying to publish some guidelines looking at, well, should we just do imaging every 1 or 2 years for at least 10 years? And of course, it's an individualized decision as to whether we continue monitoring after 10 years. Sorry. There we go. Surgery can also be useful in metastatic neuroendocrine tumors. So for some patients in some centers, they might opt for prophylactic removal of the small bowel primary. So even if it's asymptomatic. There's some retrospective data. There's a meta-analysis at the top to suggest that this may result in better outcomes. And part of the reason may be that patients with small bowel primaries produce serotonin, and that causes local changes in the bowel, obstruction, fibrosis, and pain. And if that continues, it may be difficult to do surgery later on, even if the patient is symptomatic. And this is still a controversial area, though. Debulking surgery is sometimes helpful as well, both of the primary as well as of hepatic metastases, particularly to aid with hormonal control. But recently we looked at a series of, I think it was about 60 patients who had cytoreductive surgery, even in the presence of disease outside the liver. In the experienced hands, this can be well tolerated and result in good outcomes. Liver-directed therapy in neuroendocrine tumors, that can consist of embolization, together with or without chemotherapy, as well as selective internal radiation. And all of these can be useful for reducing hormonal burden or for oligoprogression in the liver. There's randomized trials at the moment going on in the US to look at the different efficacy of these approaches. But I think there's too many options, and one of the difficult things for patients to come to grips with is, well, if I've got so many options for my grade 1, grade 2 disease, which one do we choose? I'm going to talk about them briefly towards the end of this presentation. So the first one I wanted to talk about was somatostatin analogues. So well-differentiated NET cells generally express somatostatin receptors, and I'm sure we'll talk about this in the nuclear imaging section as well. So it has somatostatin, when applied to these receptors, has both direct and indirect anti-proliferative effects. But native somatostatin has a very short half-life, so continued infusion will be required to maintain effective concentrations in the body. Currently, octreotide and lanreotide are long-acting analogues which are used in clinical practice. The general side effects include some discomfort, bloating, or diarrhea, but this tends to improve after the first 2 or 3 months. For octreotide, patients can receive a small test dose before having the long-acting injection, just to make sure they don't have very severe side effects from it. There were 2 randomized controlled studies. The first one was PROMID, which was looking at octreotide in small bowel neuroendocrine tumors. And the second one was CLARINET, which looked at lanreotide in gastrointestinal neuroendocrine tumors. And there are some differences between them, but both of them showed that somatostatin analogues delayed the progression of disease compared to patients who had placebo. There's a new drug that is hopefully coming into the market in the next few years called telotrestat. This drug is an oral serotonin inhibitor, so it stops the production of serotonin in a different way to somatostatin analogues. There was a trial looking at patients with refractory carcinoid syndrome, so patients who had 4 more bowel movements a day, and it showed that people who received telotrestat had an improvement in bowel movements. I think the figure was about 1.5 less bowel movements a day. There are some side effects, so nausea, constipation, derangement in liver function tests, and potentially depression, because we know that serotonin synthesis is potentially associated with mood changes. That doesn't seem to be a big concern in the trial so far, but it's something we look out for clinically. I don't think this drug is available in Australia as yet, but there was a positive trial last year. Everolimus is another drug that we use quite commonly for management of advanced neuroendocrine tumors. So this is an inhibitor of mTOR, so the mammalian target of rapamycin. mTOR has a critical role in both protein and lipid synthesis and energy regulation, and is upregulated in many neuroendocrine tumors, which is why it's used. The side effects include stomatitis and diarrhea, but the things we worry about as clinicians are hyperglycemia as well as pneumonitis, because patients may not necessarily know these things, and so we usually counsel patients to let us know if they've got a dry cough or even mild shortness of breath, and that might mandate CT and a CT scan of the chest, as well as a referral to a respiratory physician. There were multiple randomized trials of everolimus in neuroendocrine tumors. 2 of them were positive for gastrointestinal and pancreatic neuroendocrine tumors. And you can see the Kaplan-Meier curves there, showing an improvement in progression-free survival. Sunitinib is the other drug that we use as targeted therapy in neuroendocrine tumors. This is a multi-targeted tyrosine kinase inhibitor, and there was a phase 3 trial again showing improved progression-free survival. The side effects are slightly different. So hand-foot syndrome, stomatitis, and fatigue. So for example, if we had a patient with pancreatic neuroendocrine tumor and we had to choose systemic therapy, well, if they had diabetes, we would probably think that there would be a relative contraindication to the use of everolimus, or if they had severe hypertension, then we would probably think this was a relative contraindication for sunitinib. So sunitinib was only shown to be effective in pancreatic neuroendocrine tumors, but the RADIANT trials showed that everolimus is useful in pancreatic as well as gastrointestinal or lung neuroendocrine tumors. So the summary of all the slides and the boring Kaplan-Meier curves is grade 1 to 2 neuroendocrine tumors can be treated with somatostatin analogues. Pancreatic neuroendocrine tumors can be treated with sunitinib or everolimus, and GI or lung neuroendocrine tumors can be treated with everolimus. I know that there are differing opinions regarding the use of interferon and chemotherapy internationally. Chemotherapy is often used in grade 3 neuroendocrine carcinomas, particularly with the use of platinum doublets as first-line treatment. There's increasing use of CAPTEM, so the combination of capecitabine and temozolomide for grade 1-2 tumors, And also, it's being considered for some patients with well-differentiated grade 3 tumors, but the evidence for this is relatively little at the moment. There have been a lot of chemotherapy regimens that have been tried in low-grade neuroendocrine tumors. None of them have been shown to be better than the others. Some of them are listed there, but CAP-10 again looks promising in this regard. Interferon can be one of those options when you start running out of other options, but it's associated with significant side effects, particularly decreased mood, fatigue, and anorexia. It might be used after targeted therapies stop working. I just wanted a quick word about carcinoid crisis, which is when carcinoid tumors make excessive amounts of hormones. So patients can get extremely sick. They can have refractory hyper or hypotension caused by a flood of vasoactive compounds. And the treatment isn't more fluids, the treatment is just as much octreotide as you can get your hands on, essentially. It most often happens intraoperatively, so with resection of liver metastases. There's a few case studies of patients who might have had it around the time of PRRT, but I don't think there's a lot of data on this at the moment. In terms of ongoing trials in this space, there are trials regarding somatostatin analogues, so whether we should use them as maintenance therapy in various settings, such as after resection of tumors, increased dose of an SSA, investigation of novel combinations, so the combination of a targeted agent and chemotherapy, and also optimizing chemotherapy. So in Australia currently, we have a multi-center trial looking at the combination of carboplatin etoposide versus carboplatin nab-paclitaxel. And there's a trial in the US looking at grade 3 neuroendocrine tumors, randomizing to CAP-10 versus the standard regimen of cisplatin etoposide. And obviously PRRT trials that I think the subsequent speakers will talk about as well. So where do we go in neuroendocrine tumors? We've established that there are multiple treatment options. People are trying to put them together for patients as best as we can. But right now, we still have a big unmet need. In some particular areas, for example, with grade 3 neuroendocrine tumors, none of the targeted therapies of somatostatin analogues have been shown to be useful in this context. So what next? Immunotherapy is the buzzword for, I think, most tumor types at the moment. And there's multiple trials ongoing in neuroendocrine tumors. I think there's one that's international that many sites in Australia have been involved in, one that we helped start in Canada. And I guess the rationale behind this was that there were significant response rates with immunotherapy in Merkel cell carcinoma, which is to some extent related to neuroendocrine tumors. One trial was reported at ESMO last year, which was the Keynote-028 trial. It showed relatively disappointing response rates for single-agent PD-1 inhibitor. So the response rates range from 6 to 15%. But I think we await the full publication to see, well, are there biomarkers that might improve the efficacy of immunotherapy? And what about high-grade neuroendocrine tumors? Because all the patients enrolled there were probably low-grade. We also need to make better use of our current therapies. Do we use therapies at the same time, at different times sequentially? Do we increase the dose? Is it safe? And what about adding things like external beam radiotherapy that we haven't managed to use previously in this disease? Ultimately, the more biomarkers we've developed, the better we can choose these diseases for the right patient at the right time. So in conclusion, neuroendocrine tumors arise from multiple locations, most often in the GI tract of the lung, and are extremely heterogeneous. Diagnosis is often delayed because of the lack of NET awareness and non-specific biomarkers. Treatment is multidisciplinary and depends on grade, and consists of surgery, liver-directed therapy, systemic therapy, and PRRT, as well as not forgetting about hormonal overproduction in selected patients. So ultimately, if we manage to all work together, hopefully we can continue increasing the outcomes and increasing the quality of life for patients with this uncommon tumor. Thanks very much.
Thank you very much, Dr. Chan, for this wonderful overview. As these are plenary lectures, there is no discussion, but I want to hand over a small appreciation to you.
Okay, our next speaker is Grace Kong, who's a nuclear medicine physician from the Peter Mac, where she's a key member of the neuroendocrine tumour team, and she'll be talking about the role of PET imaging in neuroendocrine tumours.
Thank you very much, David, for the introduction. So today I'll be speaking on the role of PET imaging in neuroendocrine tumours. However, to start, I would like to ask a question. Which is the best diagnostic imaging test to detect neuroendocrine tumours? Is it conventional imaging using CT, MRI, or ultrasound? Is it somatostatin receptor imaging? And what about F18, FDG, PET-CT? Well, I think each of these modalities actually play a very important role because, in fact, they provide different information. So conventional imaging like CT or MRI definitely gives very good anatomical definition, and it gives information about vascularity, for example. SSTR imaging looks specifically at somatostatin receptor expression, which is typical or indicative of neuroendocrine tumors. And as you all know, F18 FDG really looks at glycolytic activity or cellular proliferation. So they actually provide very different information, and I think they are actually complementary tests, because particularly neuroendocrine tumors are very heterogeneous diseases. So today's talk, we will basically cover the following topics. I'd like to focus on gallium dotatate PET-CT, presenting some evidence, clinical applications, and discussing some interpretation pitfalls. Then we will follow this on with discussing about F18 FDG PET-CT and its role in neuroendocrine tumors, the role of dual tracer imaging, particularly in treatment planning for NETs, and also towards the end covering some new and other agents, including copper, peptide imaging, GLP-1 receptor peptides, as well as CXCR4 ligands. So, although conventional CT remains most widely available and is usually the first imaging modality that is performed to detect malignancy, CTs do have limitations, however, in diagnosing NETs. And that is because NET lesions typically enhances with IV contrast and is best seen on arterial phase CT, and it's actually not very well defined on other phases at all. So we have to remember that performing a triple phase CT is actually very, very important in the diagnosis and detection of NET lesions. And also using a similar protocol is also as important for restaging because you need to have comparable data to compare for restaging purposes. Somatostatin receptors are actually highly expressed in the majority of well-differentiated NETs. So up to 95% can have a high somatostatin receptor expression in well-differentiated pancreatic tumors. These receptors can be detected by molecular imaging techniques, and traditionally really by indium octreotide SPECT images, but more recently really been taken over with imaging by gallium dotatate PET-CT. But particularly when the somatostatin receptor expression is very high, we can also potentially apply therapy using PRRT as a theranostic option. As you all know in this audience here, that nuclear medicine has really significantly evolved over time. Not only do we now have better radiopharmaceuticals, radiotracers, camera and technology have also improved. We've come a long way from planar imaging to SPECT, to SPECT-CT, and then to PET-CT. And really, it's the evolution from SPECT to PET imaging that has really created a new paradigm for somatostatin receptor imaging, particularly to look at neuroendocrine tumors. So traditionally, SPECT using indium labeled with DTPA octreotide. Now we can do it with PET imaging using gallium DOTA octreotate. And gallium is a generator-produced positron emitter. It has a very short half-life of 68 minutes. And there are also a variety of different peptides we can bind or radiolabel for imaging purposes. But the most commonly used peptide is really octreotate because it has the highest receptor specificity for somatostatin receptor type 2, which is the most abundant receptors usually in neuroendocrine tumors. And clearly, PET imaging has vastly superior diagnostic quality compared to SPECT imaging. As you can see here, the same patient imaged only 4 days apart. The PET images produces much better imaging quality. We can see much more lesions than the indium octreotide SPECT. And overall, Really, PET images is much more accurate. It has a much higher sensitivity, specificity, faster imaging time compared to the traditional indium octreotide SPECT. It can provide quantitative information, lower radiation dose because of the shorter half-life, and it is definitely more cost-effective. And it is really encouraging to see that this new technology of PET has been embraced really by the community and by authorities, because it is now this imaging technique is approved in America and recently also approved in Australia for certain indications, which is very encouraging. So small lesions that are otherwise very difficult to identify even on the arterial phase CT here can light up very, very brightly on the PET's, gallium PET. In terms of guidelines, several international guidelines have been published, and the most recent one being the ENETS guideline, which is from the European Neuroendocrine Tumor Society that was published back in December 2016. There's a more recent guideline published by the EANM of last year, and these certainly incorporate very, very detailed imaging protocol and make some very, very good reading material. But overall, these guidelines really nicely summarizes that gallium PET has a much higher sensitivity than CT in terms of detection of lesions. As you can see from the table on the top, the sensitivity for diagnosis of NET lesions really ranges between 50 to 80%, but with gallium PET CT, which is a table down below, shows a much higher sensitivity. In particular, I would like to draw your attention to the diagnosis of bony metastases, because these are certainly much better defined and picked up on gallium PET, and they can easily be missed on the CT scan. Also, a recent meta-analysis has been published looking at over 1,000 patients. I don't intend you to read all of the small prints up here, but really just to show you a table that most recently there has been quite a few studies published, data on gallium dotatate PET CT. Whilst most of these studies are retrospective, at least 5 of them are prospective studies. And overall, they do provide a very consistent message saying that gallium PET CT has much higher diagnostic accuracy compared to CT or conventional imaging, as well as indium octreotide imaging as well. But the main message here is that a change of management was overall also detected in about 44% of patients who had a gallium PET. And in particular, a high proportion of management impact actually resulted in intermodality changes, so from one modality to another. For example, a patient who was meant to be surgically, have the lesion surgically resected after a gallium PET, finding out more lesions, ended up having systemic treatment, so up to 77%. So it really has a very huge clinical impact. So I would just like to give you a few examples of the clinical role of gallium PET CT. Firstly, it is very useful in localizing small primary tumors. As you can see here, this patient has a very, very small gastrinoma, which highlights, lights up very brightly on the gallium dotatate PET CT, but it was otherwise not detectable on any other conventional imaging at all. Gallium PET CT can also be useful for the detection of metastatic disease sites. So this patient has presented with a small bowel obstruction and had a small bowel primary resected. And after surgery, with conventional CT imaging, there was no evidence of any pathological abnormalities at all to suggest metastatic disease. However, this patient continued to have an elevated chromogranin A level and had a gallium PET CT performed, which highlighted 2 lesions with high somatostatin receptor expression, which is consistent with metastatic disease, but they are very, very small, and even by size criteria, not considered to be positive on CT scan. And these lesions were proven to be metastatic because upon restaging, they progressed, as well as new lesions highlighted by the green arrows actually developed over time as well. Here is another example showing how gallium PET CT can be useful to detect recurrent or progressive disease. Here is a patient with a solitary SSTR-positive liver metastasis. A patient underwent local ablative therapy, and after ablation treatment, the patient had restaging, not expected to have any residual disease really. The post-therapy scan very nicely show a hypodense region in the CT consistent with the area where it was ablated, but the red arrow points to a lesion where it's just at the edge of the ablation, consistent with a focus of residual uptake or disease. And as well, the gallium PET-CT had picked up 2 other sites of extra metastases that had developed in the interim, again, not picked up by any other conventional imaging. And gallium PET-CT is also very useful to help monitor therapeutic response to treatment. The picture on the left shows that the patient has multifocal somatostatin-avid metastatic disease. The patient underwent 4 cycles of peptide receptor radionuclide therapy, showing a very, very significant response during treatment, as well as up to 3 months after the cycle 3. And very nicely showing on the serial images here that there's been a significant response. And in fact, some of these bony lesions that was picked up at baseline on the gallium PET was actually not evident on the CT at all. So despite having gallium PET having much better diagnostic accuracy, I think one of the main advantages of gallium dotatate PET-CT is to be able to select patients for theranostic treatment. So studies have shown that lesions with a high somatostatin receptor expression, particularly those with uptake greater than physiologic liver or splenic activity, creatinine 3 and creatinine 4 uptake, they tend to do much better in terms of having percentage of remission. So basically, lesions that have creatinine 3 or 4 uptake really can be considered suitable for PRRT treatment. And if there is very high somatostatin receptor expression in the metastatic disease sites, PRRT can be very, very effective, like shown in this example here, because we can really give a lot of targeted therapy to those lesions here. But theranostics and PRRT will be explained in much more detail during the next talk. So whilst gallium PET-CT is very sensitive, it's incredibly useful for picking up small lesions, I think we still have to be very careful in terms of interpreting the imaging findings, because there are some pitfalls that we have to be aware of. In particular, the uncinate process physiologically can actually look quite prominent on the GAT8 PET-CT, such as in this case. You can see that there is a very prominent focal uptake in the mid-abdomen. So if we see that, it is very common that we see physiologic uptake in the uncinate process, and in the absence of any definite mass lesions, we must remember that this is most likely physiologic. Now, splenonculi can also light up very brightly on the PET-CT images as well. So there are other conditions. Osteoblastic activity can also have increased uptake on the GAT8 PET-CT. And osteoblastic activity can come from degenerative bone disease, for example, fractures, hemangioma, or growth plates. Inflammatory conditions can also have high GAT8 avidity. So this can happen in reactive lymph nodes, for example, prostatitis or any inflammatory conditions. And meningiomas can also appear very focal and intense on GAT8 PET-CT because of the high somatostatin receptor expression. Another interpretation pitfall is that we have to remember that long-acting somatostatin analogues may actually change the biodistribution of the scan, or it can change how the scan appearances of the scan. So recently we looked at 21 patients who had a GAT8 PET-CT before and after initiation of somatostatin analog therapy. And what we found was after initiation of long-acting somatostatin analogues, we can often see a decrease of uptake in physiologic organs, such as within the spleen, thyroid, and liver. And because of this change of biodistribution and increase of bioavailability, we can paradoxically see an increase within the tumor or metastatic lesions, where the SUV actually goes up in the lesion sites. So here I have an example of a patient who had a baseline image here, as well as GAT8 images on the right-hand side after initiation of somatostatin analogues. And you can see that the thyroid activity actually goes down, physiologic splenic activity reduces, as well as physiologic liver activity appears lower as well. But paradoxically, the tumor lesions actually appear more intense. For example, this green arrow here pointing to a very tiny lesion the SUV has gone up from 4 to 7, and several other sites also appear more intense as well, such as this one and this one here. So we just have to bear in mind that patients who are on long-acting somatostatin analogues, if we see an increase of tumor uptake on the Gate PET-CT, it does not necessarily infer to disease progression, particularly if there is no evidence of structural progression or there is no evidence of clinical biochemical progression. So that's something to bear in mind. Now we'll move on to what about F18 FDG PET-CT. As you all know, active cancer cells utilizes increased glucose uptake and therefore increased glycolysis and therefore high FDG uptake on the PET-CT images. In regards to neuroendocrine tumors specifically, usually a positive FDG PET scan is associated with NET of a higher proliferative rate or grade. As you can see here, when the Ki67 value increases, from a low grade to a higher grade tumor, the rate of positivity of the somatostatin receptor imaging actually goes down because as the grade of tumor increases, as they become more aggressive, tumors may actually lose somatostatin receptor expression. But on the other hand, is a flip-flop phenomenon for the F18 FDG PET-CT because as the tumor grade increases, the rate of positive FDG actually goes higher as well. So a positive FDG is usually associated with more aggressive tumors. And not only does it infer to the proliferative rate, it also can predict prognosis and survival. Binderup et al. Has demonstrated very nicely that NET patients with PET-positive disease has a worse overall survival than those patients with negative FDG PET-CT. As well, Guerin et al. Also show a very similar phenomenon where patients with a positive FDG PET usually does worse in terms of overall survival and PFS compared to those with PET-negative disease. Whereas on the opposite side, when patients have positive somatostatin receptor expressing disease, inferring well-differentiated tumors, these patients actually do much better in terms of overall prognosis, overall survival, and PFS. So that comes to the question, why do we use dual tracer imaging for neuroendocrine tumors? Well, that is because neuroendocrine tumors is actually not homogeneous. Even within the same patient, we can see great heterogeneity at diagnosis. And now we recognize that there is a phenomenon called combined tumors, where even within the patient can have a component of well-differentiated disease together with a high-grade component. And grade of the disease can also be different between the primary tumor and metastases within the same patient. This is actually quite interesting. You can see this graph here, where the arrow is pointing to is that there's a range of Ki67 index within the same patient between different tumor sites. So the primary tumor, in this particular case, has a very low Ki67 index, so grade 1 disease, but metastatic lesions, some of them actually have Ki67 of over 20%, which is a grade 3 component. So these diseases can be very heterogeneous even within the same patient. Another interesting phenomenon is that disease heterogeneity can also change with time as well. This is quite an interesting paper where they looked at a group of patients with small bowel as well as pancreatic neuroendocrine tumors. At the time of diagnosis, they characterized the Ki67 index. But at the time of progression, patients actually underwent rebiopsy. And with rebiopsy, you can see that the Ki67 profile can change quite significantly over time, especially from a lower grade to a higher grade Ki67. So dual tracer imaging really can provide a very, very powerful tool to help characterize disease heterogeneity in a non-invasive manner. So just to remind you that Gate PET-CT is usually positive with somatostatin receptor expressing disease in the low-grade tumors, whereas FDG PET-CT is usually positive when patients have poorly differentiated phenotype. So we basically have observed three different types of phenotype, three different phenotypic appearances. So patients can have somatostatin receptor positive PET-CT, but a negative PET-CT scan. And this usually applies to patients with very indolent low-grade tumors. So they have very well-differentiated disease, but not using up glucose at all. So it usually infers to people who have grade 1 tumors. The second phenotype is a concordant one. So patients can have somatostatin receptor expressing tumor, but these tumors also concordantly show glucose activity. And this usually infers to more aggressive tumors, usually grade 2 or even a low grade 3 phenotype. But they're more aggressive than the first phenotype that I had just shown you. The third phenotype is what we call being spatially discordant. So it just doesn't actually match each other. So some lesions can actually be somatostatin receptor positive. Some lesions, however, can be FDG positive. And this usually applies to patients with very poorly differentiated disease, aggressive tumor. So dual tracer imaging can really help us to characterize the phenotype in biology. SSTR PET looks at somatostatin receptor expression. FDG looks at glycolytic activity. And the combination of these can really give very comprehensive information about the diagnosis to characterize whether the patient has heterogeneous disease or not. It can guide prognosis. If there's FDG-avid disease, usually patients do worse. And in particular, it can also guide us where to biopsy the patient, because if you biopsy this lesion here where the green arrow is pointing to, you would definitely get a well-differentiated pathology specimen back. However, if you biopsy this area here, where it's intensely FDG-avid with minimal somatostatin receptor expression, undoubtedly it would yield a high-grade pathology. So it's very, very important to get the diagnosis and staging correct in the first instance, really to guide appropriate therapeutic options and management for the patient. So FDG PET-CT usually can be considered when the Ki-7 index is greater than 5%. If you see lesions on CT without any somatostatin receptor expression, then you can consider doing FDG to further characterize that area. And also when patients have more rapid progression than expected for the grade, then I think an FDG PET-CT should be considered. And the dual tracer imaging approach can also help to guide whether the patient is appropriate for theranostic therapy. So if all lesions contain high somatostatin receptor expression, despite having concordant FDG uptake, patients can actually respond very well to PRRT as long as we can target all the lesions with lutetium. However, if the disease with lesions without somatostatin receptor expression, however, cannot be targeted by PRRT. So this is an example of a patient with a very large area of FDG-avid disease, but only with very patchy somatostatin receptor expression. So if you can draw a line over here, a large area of FDG-avid disease, only a small component of this is somatostatin receptor positive. If we give lutate or PRRT to this patient, it will only target a very small area of this disease, and it will not be very effective. Some of our colleagues from New South Wales in Australia have also come up with suggested a dual tracer imaging NET PET score, which also provides prognostic information. So what they've done is they've, using dual tracer imaging, characterized them into 5 different grades, P1 to P5. P1 include patients with basically somatostatin receptor positive but FDG negative disease. P5 are patients with totally discordant FDG-avid lesions, and P2 to 4 are those with concordant pattern of different varying degrees. And basically what they found is, I guess not unexpected, that patients with FDG-avid disease but negative on somatostatin receptor imaging, they actually do much worse than patients with somatostatin receptor positive disease. So I think really dual tracer imaging not only can just guide theranostic approach, it can also guide overall therapeutic options as covered by the first talk, because patients with significant FDG-only disease, certainly you would need much more aggressive therapy to treat these patients. So now I'd like to move on to discuss in the next last couple of slides some new and novel diagnostic agents that we may come across in the future. So one of them is copper-64. So copper-64 has been labeled with dotatate for somatostatin receptor imaging. And at least recent head-to-head comparison between the conventional gallium dotatalk versus copper dotatate has shown that the copper studies lesions have a higher targeted background ratio. More lesions can be detected, so at least comparable to the gallium dotatalk PET. One of the advantages, however, of using copper-64 is that it has a much longer half-life of 12.7 hours as opposed to 68 minutes. And so this longer half-life potentially can allow for delayed imaging and possibly individual dosimetry for therapy purposes. However, despite having this theoretical advantages of having long half-life, in reality, the delayed images are actually a bit suboptimal because, as you can see, there is very poor late retention, of the tumors on 24-hour imaging. And that is because copper doesn't actually bind onto dotatate in a very stable manner. So with time, it actually falls off. So, this really severely constrains the ability to do any prospective dosimetry or therapy. There's been some recent developments, however, that can provide a potential solution to this problem. So copper can be labeled with sarcophagein. So the new agent compound is called copper sartate. And you can see from the images that at 20 hours, there is high uptake and retention of the tracer, even on delayed imaging. So this compound, sarcophagein, can lead to much more stable copper-64 binding, allowing for potential prospective dosimetry. And there is also a potential theranostic pair with copper-67 as well. So GLP-1 peptides, it's useful to image benign insulinoma lesions because they highly express the GLP-1 receptors. And recent studies have looked at indium, DTPA, exendin-4 SPECT-CT. This is a prospective study. Another prospective study using technetium-labeled exendin-4 SPECT-CT, but more recently, gallium DOTA NOTA exendin-4 PET-CT, really showing a much, much higher sensitivity than conventional imaging and even EUS in detecting these benign insulinoma lesions. And here's just a case of a patient who is symptomatic, negative conventional imaging, but the GLP-1 imaging here clearly highlights a lesion that was after resection confirmed to be a benign insulinoma. So just lastly, CXCR4 ligands is also a potential novel diagnostic agent for neuroendocrine tumors, particularly to image poorly differentiated neuroendocrine tumors. As you can see here, gallium pentixafor PET-CT in a recent study was actually positive in 80% of G3 tumors and 0% positive in G1 tumors. And in this example here, you can see that this patient with a neuroendocrine tumor with a Ki-67 of 90%, so very high-grade tumor. This particular area showing negative DOTA-TOC uptake, very highly FDG avid, so aggressive phenotype, but also very highly avid on gallium pentixafor PET-CT as well. So the authors here have also concluded that this is a potential use for poorly differentiated NETs and potentially also for theranostics for this group of tumor in the future. So we watch this space. So to conclude, molecular imaging using somatostatin receptors and FDG PET can non-invasively characterize NET disease biology and phenotype. Functional imaging can definitely guide diagnosis, prognosis, particularly guiding a biopsy site. It's useful for restaging and also personalized therapeutic, to guide personalized therapeutic options. Novel traces may also contribute to NET imaging and theranostics in the future. And given the complexity of the disease, individualized approach is definitely crucial for this malignancy. So I thank you all for your kind attention. And can also please take this opportunity to invite those of you who are interested in neuroendocrine tumors to come to APNET's meeting, which is the Asia Pacific Neuroendocrine Tumor Society, which is held later in the year in November here in Melbourne. So please let your colleagues at home know about this meeting if you're interested, and we look forward to seeing you here. So thank you very much.
Okay, thank you, Grace, for that very comprehensive presentation. And here, I'll just give you this as a small memento of your presentation.
Thank you. So we come to the last presentation of this session, which will be presented by my co-worker, Dr. Aviral Singh. And the lecture is entitled Theranostics of Neuroendocrine Neoplasms, Past, Present and Future of PRT, And I would like to ask Dr. Singh to give the presentation.
Thank you very much for the kind introduction, and thank you, organizing committee, for the opportunity to speak in this forum. So essentially, I had a long list of tasks here for this lecture, but I guess the first two have already been very efficiently performed by my previous speakers. So I'll skip those, but to summarize what the first speaker said, I guess what we're heading towards, especially in neuroendocrine tumors and in general in oncology, is personalized medicine, which is essentially the right treatment for the right patient at the right time. And as very aptly put by one of our leading patient advocates, with the right dose. And also, it's more or less a tailored suit and not a one-size-that-fits-all for patients. With regards to summarizing what Dr. Kong said, is that essentially what molecular imaging for theranostics is more or less one stone that kills 2 or 3 birds at the same time. So, the pathogenesis, you can diagnose, and then you can do treatment planning as well. So essentially simple in concept, but very effective in execution. Now, the basis of PRRT is essentially theranostics, and if you see in the over the last almost 2 decades, there's a sharp rise in publications and interest in the medical field with regards to theranostics. And that's just the list of literature that's published and can be seen on PubMed. Right, so theranostics is basically based on a lock and key principle, and it's essentially what we see, we treat what we can see. So you'd have your the target here, which would be your in the case of neuroendocrine tumors would be your somatostatin receptors on the cell membrane. And the key here consists of the peptides or ligands that we could use attached to a linker, which is also responsible for joining the chelator and the ligand, and also partly for the biodistribution of the radiopharmaceutical. And then you have the cage, which is the chelator, which holds in itself either a reporting unit, which is used for diagnosis. Mainly, the mainstay today for diagnosis is gallium, and the cytotoxic unit, which would provide the therapy, which mainly currently we are using lutetium or yttrium as well in certain centers. So the key sits into the log, binds to the target and gets internalized, and that's where the action takes place, whether it's imaging or it's therapy. PRRT has essentially been a very long story for several decades now, from the first autoradiography of isolation of somatostatin, and then following several years later, the first PRRT with high-dose indium, followed by yttrium octreotide in Basel, and then lutetium. And over the years, it took several decades for the first trial to be initially registered, and then the results were reported of NET-1 that we all know at ESMO in 2015, followed by approval of Lutathera by EMA, the European Medicines Agency, in September 2017, and eventually by FDA in January 2018. The first PRRT here was performed by Professor Krenning, and it was published in 1994. So it took over 20 years from the first report to EMA approval. There have been lots of single-center studies, which you can see here, and which provided the basis of phase 2 trial basis for the NET-1, which was a landmark trial publication in theranostics. So a phase 3 trial of lutetium dotatate, particularly for the treatment of mid-gut neuroendocrine tumors. Eventually, following the trial, EMA, we've spoken about the EMA approval as well as the FDA approval. The trial took place in 51 centers in 11 countries in the USA and Europe. So the trial was a multi-center stratified open randomized phase 3 study. There were 2 arms. The first arm was the lutatate arm, and compared to the octreotide arm, the control arm, with high-dose octreotide, so 60 milligram. And the endpoint was to compare the PFS. So what we now have is that the PFS in the octreotide-only arm was 8.4 months, whereas in the PFS in the lutetate arm is now reported at 28.4 months. So that's a 20 months gain or addition. A very important question very often asked by our oncologists is whether the therapy is nephrotoxic or not. But here's the data also on creatinine clearance for the NET-1 trial, and over the 2-year period, observational period, renal function has remained stable with no grade 3 or 4 nephrotoxicity occurring in these patients. Another very important factor for all our patients is their quality of life. The NET-1 study was very important in reporting on that as well, where treatment with lutetium dotatate has been associated with improved quality of life in several key domains, particularly in global health and diarrhea. There were also non-statistically significant improvement in QOL seen in all other domains. However, what was most important is that there was no evidence of decreased quality of life for these patients who received lutetium dotatate therapy. There's another trial which has already been started in 2017, the COMPETE study. This is a controlled, open-label, multi-center study of PRRT with lutetium edotriotide, and it is comparing to targeted molecular radiotherapy with Everolimus in neuroendocrine tumors, so not only mid-gut, but also pancreatic NETs. At our center, we are currently performing about 400 PRRTs per year, and we've been certified as an ENETS Center of Excellence since 2011. The most important part in any treatment for these patients, which can be very complex, especially the functional patients with the multitude of symptoms that they can have and the disease which leads to complications, it's very important for a tumor board to be essential part of your treatment planning. And for all complicated patients, you can get an excellent help with your colleagues. At our center, the patient selection for personalized PRRT is based on the Bad-Burka score, where we take into account the SUV, also renal function, the hematological status of these patients, and of course, as you've heard in the previous talk, very important is the FDG status because of the heterogeneity of the tumor. And we strive to perform, or we do perform, FDG initially in all patients so that we can, at later stages, monitor the dedifferentiation of the patients in case the tumor becomes aggressive. So we believe in a more, as I said, multidisciplinary team approach, and it's more or less based on individualized therapy plan. We believe in frequent cycles with low to intermediate doses of radioactivity, so long-term, low dose, and not a short-term high-dose concept. We do use both lutetium and yttrium, and as we discussed earlier yesterday, we do perform intra-arterial PRRT as well. Standardized evaluation is performed by systemic restaging in all patients, and we submit all our data to a prospective clinical database. So the advantage of using both yttrium and lutetium is that the lutetium, with its lower penetration range and lower energy, actually is less toxic to nephrotoxic or hematotoxic. But it is difficult with lutetium only to treat large tumor burden and large metastasis. Therefore, yttrium-90 with its longer penetration range as well as higher energy is more effective to that. So far, we've treated over 1,500 patients with more than 5,500 cycles. And the median age being about 60 years patient. The maximum number of tumor entities that we see here is pancreas NEN and almost a similar amount of midgut tumors followed by others. Recently, we've published our results. This is EPUB ahead of print. We've published our results in Oncotarget for PRRT with radionuclide therapy, both with yttrium and lutetium in over 1,000 patients. So essentially, over 2,000 patients were screened following a tumor board. 570 were not eligible. Over 670 were eligible, but received other treatments. So intention to treat analysis was performed in 1,048 patients. The results of this retrospective analysis show that patients with neuroendocrine tumors of small intestine had the longest median overall survival of 69 months. And the lowest was seen in the group with lung neuroendocrine tumors. Again, patients with G1 neuroendocrine tumors had a better survival, 88 months compared to G3-NEN, which is 23 months. This is a case where you can see of a patient with well-differentiated non-functioning neuroendocrine neoplasm of the rectum who had persistent remission of multiple liver metastasis 3 years after 3 cycles of PRRT. And not only the metastasis, but also the primary tumor showed less uptake and was reduced in size on CT, showing objective response. Okay. So this is a case of a patient where PRRT, due to objective response and shrinkage of tumor burden, can also improve parallel clinical conditions which the patient may be suffering from. So this is a case of a patient who essentially had a tubal extraction rate performed by MAC3 renogram of only 35%. The patient received PRRT here once and then again second time, and the TER actually improved. So you can see this is the kidney here, which is pushed by the tumor mass. And once the tumor mass resolves, there is no compression by the tumor load on the kidney and its function. So this again shows very clearly the reduction in the tumor mass, and thereby improving, and also you can see the size has reduced, and thereby improving renal function in this patient. So it's not only the uptake or hot or cold lesions or whether you can see activity or not, you actually see objective response with reduction of size and tumor mass, particularly if there are large lymph nodes. So the safety data has been published by Dr. Lisa Bodai, where this paper was adjudged the best clinical paper in EGNMI in 2015. She has assessed the safety profile of PRRT in 807 patients. So one can see here that in these patients, with regards to nephrotoxicity, grade 3 and 4 nephrotoxicity was only seen in patients who had actually received yttrium or with lutetium had received yttrium. No patient receiving lutetium showed any grade 3 or 4 nephrotoxicity. So that's, again, a very important message to pass on to your oncology colleagues. With regards to hematological toxicity, severe hematotoxicity such as MDS or AML was seen in less than 3% of this patient group, which according to other studies, single center studies, relates to a similar number, about 2 to 3%. So initially, the PRRT was first included in the ESMO guidelines as early as 2011. However, we would be expecting an update very shortly because the working group is trying to finalize the details of the sequencing of PRRT and other therapies with latest evidence, and we're expecting PRRT to come up slightly higher in the algorithm, but we'll wait for that. The latest guidelines that are to be followed are those by the ENETs, where PRRT is again included, both for intestinal NETs as well as pancreatic NETs. Right, so this is where we are at this stage, but what does PRRT hold for in the future? It's a very, very long list with multiple combination therapies, some of which have been shortly discussed and hinted at by my previous speakers as well. Then there's newer radioisotopes. There is, centers have used alpha therapy as well with bismuth actinium intraarterial approaches as well. And there are, as Dr. Kong just showed, there are possibilities of using new theranostic pairs, such as she mentioned the copper 64-67, but there are others in the process as well. Novel targets, somatostatin receptor antagonists, as well as CXCR4 and GLP-1 was just again mentioned and aptly demonstrated by my colleagues. How do we prognose the therapy effect, the toxicity of these patients? How are we related to all the therapies they've had before? Instead of fighting at each other and complaining, do we need some biomarkers to tell us where are we going with the therapy? So very recently we've developed in association with Rotterdam as well as Meldola, and also a center with in US, we've developed liquid biopsy leading to a NET test result where you can take the blood sample, perform gene transcript analysis for 51 genes, and get an answer as well. There's radiomics. There's a lot which can be prognosed by using radiomics, and this has already been shown, for example, in breast cancer and lung cancer as well. And there's work going on currently in our field as well. DO-PRRT, tandem PRRT, where in DO-PRRT you use either the both lutetium and yttrium, but in sequence. You can alternate depending on the tumor mass, depending on how the patient is progressing on their clinical condition. You can perform tandem PRRTs. You can use both yttrium and lutetium simultaneously in one therapy approach or application, just in two different ways. And of course, there certainly needs to be improvements in dosimetry, because there's always the question, how much can you give, which nobody has a true answer to. So this is an example of DO-PRRT in a patient, 72-year-old patient with well-differentiated functional pancreatic NET, Ki-6710 with extensive liver metastasis, received 4 cycles of PRRT. The first was with yttrium and subsequent with lutetium, and there's partial remission again. Not only is there reduction in uptake, but you can clearly see reduction in volume and the size of the liver metastasis. And this was again shortly spoken by Dr. Chang earlier, that combination with surgery is also very important. This is a paper published by our group, a surgeon at our center, where he's shown that combination PRRT and surgery are very effective, and it is always better to have the tumor which can be removed, particularly the primary tumor removed, which relates itself in due course to better survival following PRRT. Okay. Again, the role of PRRT is also important in cases where, such as neoadjuvant PRRT, there are lesions where you need to shrink the tumor burden so that the surgeon can actually go in and perform surgery. This is one of the cases as well, and the patient following Whipple's Whipple surgery, the patient had for a pancreatic NET, neoadjuvant PRRT was performed, and histology revealed completely total tumor necrosis in a radiation necrosis following PRRT, and the patient has been in remission for over 10 years now. PRCRT, so combination of PRRT with chemotherapy, either as mainly as radiosensitizers as well. We've been using it for a long time. However, with regards to systematic studies, Australia has been leading the way, and there are certain single center studies reported already by Professor Harvey Turner and Professor Claringbold, and also by the Peter Mac group. And there's another study here by the Australian Gastrointestinal Trials group, where they're comparing lutetium dotatate versus Captem in both pancreatic NET and small bowel NETs. So this is a case from Peter Mac, a patient 46-year-old with rectal NET, Ki67 40%, who actually progressed following 6 cycles of carboplatin, but following that he had 4 cycles of lutetium-177 therapy and had a near complete tumor response to such a huge tumor burden. There's also the role now in G3 neuroendocrine neoplasms. So if you know about the Nordic NET study performed by Professor Halfdan, Sorbe Halfdan, he reported that the take-home message from that study was that patients whose Ki67 is less than 55 perform better in the long course, but they perform poorer with chemotherapy. So should every patient get chemotherapy when their Ki67 is more than 20 and up to 55 is also questionable. A recent publication from the Peter Mac group shows that, again, with a cutoff Ki67, that PFS for patients with Ki67 less than 55 was way longer than those treated than compared to the Nordic study, and as well as the overall survival was significantly better at 46 months compared to 19 months in the Nordic NET study. At our own center, we've also performed survival analysis for patients with G3 NENs. So the cutoff for this list was 40%. We've seen a median PFS of 9.6 months and a median overall survival of 20 months in this patient group. Alpha therapy, and again, this could be used for patients who are resistant to lutetium. This work was demonstrated by the DKFZ group, who've clearly shown that following failure of lutetium therapy, one can perform intra-arterial alpha DOTATOC therapy, resulting in complete response of these. It's not going back. Okay, of this tumor burden here. And this was also, this image was also the SNMI image of the, in 2012. So then what are the strategies to identify PRRT efficacy prior to therapy? Individual assessment of therapy response after PRRT. So initial works, as I had mentioned earlier, were performed by our groups together with the Italian, the Holland and Bad Berka group, who first found this gene transcript analysis to assess effectivity or efficacy of PRRT in patients. It was followed up by more work with with control groups. So initially at Meldola, then compared with control groups at Bad Berka and Rotterdam. And this is the publication in EJNMI recently. It's online, but ahead of print again, where the discovery cohort, followed by the Bad Berka cohort and Rotterdam, validated this NET test, and it is significantly, the predictive quotient is 95% accurate as overall in all patient groups combined, where we took, which was more or less a heterogeneous group with GEP-NEN, pancreatic NEN, with lung neuroendocrine tumors. So we are moving ahead as well in terms of prognosticating the efficacy or toxicity of these patients, which will be the next step that we are performing. With regards to somatostatin imaging, although somatostatin agonist imaging has become the mainstay of imaging currently, however, very, very promising results have been shown by antagonists since also in autoradiographic studies performed, as well as clinical, preclinical, and clinical studies performed. Somatostatin receptor antagonists label more somatostatin receptor sites than agonists. And this leads to a higher diagnostic sensitivity. As you can see in these patients, this liver metastasis was not so well appreciated, which can be seen with the antagonist here, JR11. So essentially, since there is higher binding of the resting somatostatin receptors by the antagonists and not the active ones which are targeted by the somatostatin agonists, there is 2.6 times longer tumor residence time in the higher tumor dose as well. And the uptake is 35 times higher for OPS-201 in comparison to dotatate. And so as this is clearly depicted by the area under the curve, the red one here refers to the lutetium dotatate, and this refers to lutetium OPS-201 as well. So this should essentially head towards a better or higher tumor dose, and therefore a better therapeutic efficacy. With regards, comparison of lutetium dotatate with lutetium dota-JR11 as well, one can see that I'll just focus on that. With here, for the agonist, the mean dose achieved was 1.4 gray per gigabecquerel, and for the same lesion, with antagonist dota-JR11, the mean dose received was almost 6 grays per gigabecquerel, sorry. The tumor to kidney ratio here was about 1:1. Here it's 2.5. So there's also a risk of higher dose delivery to the kidneys, but clinical work is underway, and we'll see what the result shows. So we have been thankfully provided LM3, another somatostatin antagonist by Professor Meke. And here in this slide, you can see the dotatate, the agonist compared to the antagonist, and you can see very good, clear uptake even in osteolytic metastasis on paraganglioma. Another significant advantage of the antagonist is that there is the tumor to background ratio for liver is higher. That means the physiological uptake of somatostatin receptor antagonists is lower in the liver, thereby allowing us to detect more lesions in the liver. This is a patient who received both TOC and LM3 within a few days, and you can see detection of additional liver metastasis. Dosimetry perspectives, shortly also spoken by Dr. Kong with regards to copper-64, is also essential. And I'll just rush in view of shortage of time. So scandium, the first scandium generator-produced scandium was performed at our center by Professor Baum earlier on, and in 2009, as far back as 2009, followed by the cyclotron-produced scandium, which showed very sensitive images, where you can see on the dotatate scan, you can't see the lesion here, this tiny liver lesion, whereas it was clearly appreciated on the scandium scan. It was also not appreciated on the MRI, which was performed within 24 hours. However, later on follow-up, you could see this lesion. So I'll skip this for now. Another very significantly interesting radioisotope is the terbium, which could be called the Swiss Army knife of nuclear medicine. It's having several isotopes for therapy, for SPECT as well as therapy, and PET, and again, terbium-155 for SPECT. It has significant potential for diagnosis, pre-therapeutic dosimetry, as well as radionuclide therapy. We spoke about this in detail yesterday as well. So there's comparative studies of 152 terbium DOTA-NOC PET-CT in comparison to lutetium DOTA-NOC SPECT-CT with similar uptake, and this is very important because this could relate to pre-therapeutic dosimetry because the physical properties were found to be similar in both. We also performed the first terbium DOTA-TOC PET-CT study in humans up to over 24 hours. It was possible, which could lead to, again, performing predictive dosimetry as well as in real patients. And this is one of the publications from that study. This we've already discussed, so I will not go through that by Dr. Kong. Again, the use of copper. And in essence, to summarize, PRRT is effective and well tolerated. It not only improves survival, but it also improves quality of life for the time period that the patient is alive, and that is very significant when we compare it to other more toxic treatments, therapeutic options such as chemotherapy. Essentially, standardized treatments are already present. We can minimize or absolutely avoid renal damage, which was essentially initially a concern, mainly when high-dose yttrium was used. And one should always take into account an interdisciplinary treatment for these patients, and future perspectives we've essentially already discussed. So at this note, I'd say thank you.
Okay, thanks Avril for that great presentation, and please accept this as a memento.
So I would like to thank all speakers for excellent presentations and also staying exactly within the allowed time.